Onc Live Insights is a video editorial program produced by Onc Live.
Another promising approach to targeted therapy has been the development of a type of drug called an antibody-drug conjugate. This essentially uses a monoclonal antibody specific for a cell surface protein to specifically deliver a cytotoxic agent directly to the cancer cell. Some people use the guided missile type of metaphor for the way these drugs work. We've had very compelling proof of concept with these types of drugs. TDM1 is a HER2-specific antibody-drug conjugate, which has shown very impressive activity in the metastatic setting for HER2-positive breast cancers. And there's a drug for Hodgkin's lymphoma called brentuximab, which targets a cell surface protein in Hodgkin's lymphoma, which has also shown very impressive activity. So clearly, this type of approach can be very effective if one can identify a specific protein on cancer cells that's targetable. But based on the data we have so far, there has been a lot of interest in this field. There have already been 2 drugs which have shown some interesting levels of activity in early studies. One is CDX-011, which targets a cell surface protein called GPNMB, which is predominantly expressed in triple-negative breast cancer. And in relatively small studies, this antibody-drug conjugate targeting this cell surface protein as a single agent has shown significant response rates particularly in triple-negative breast cancer that overexpresses this target. This has now been moved into a randomized trial comparing CDX-011 as a single agent versus capecitabine in triple-negative breast cancer. And I think that this is certainly something that's quite exciting moving forward. Another interesting conjugate for triple-negative breast cancer has been IMMU-132, which targets a cell surface protein called TROP2, and that also has shown promising levels of response rates in pretreated triple-negative breast cancer. So I think this is definitely an area that is of interest moving forward. In HER2-positive breast cancer, in addition to the already demonstrated activity of TDM1, another similar approach has been with an antibody-drug conjugate called MM302, which actually is a slight twist on the idea. This is basically a liposomal doxorubicin, which is covered with antibody fragments targeting HER2. So rather than have one antibody with several chemotherapy agents attached to it, this is one large chemotherapy molecule with a number of antibody fragments attached to it. I think the general idea is similar, and particularly in patients who have not had prior anthracycline treatment, MM302 has shown promising levels of response. And there is now a randomized trial called Hermione, which is randomizing patients with pretreated HER2-positive disease to MM302 plus trastuzumab versus treatment of physician's choice. I think that this is another approach that hopefully will show similar types of activity as seen with TDM1 for patients who have pretreated disease.
With the advent of genomic profiling in the metastatic and sometimes early setting, we now know that several breast cancers may have amplification of the FGFR pathway. Initially, this was thought to be quite uncommon, specifically in breast cancer. FGFR amplification or alterations in general are quite uncommon, comprising probably way less than 10% of all tumors. Nevertheless, FGFR amplification is now emerging as a very important mechanism of resistance not only to endocrine therapy but potentially against HER2-targeted treatments and chemotherapy as well. So typically when you see an FGFR amplification, one would expect that those tumors would not behave well. These are women that will have, unfortunately, early recurrences and may not do so well with conventional therapies. There are now new drugs that target the FGFR pathway, namely FGFR inhibitors. One such drug is a medication called lucitanib. It's a very potent FGFR inhibitor that not only has activity against FGFR, but it also has activity against VEGF, the vascular endothelial growth factor receptor. Therefore, with this dual mechanism of action, this drug has actually, in early clinical trials, have shown activity against cancers that have FGFR amplification. There are current clinical trials being done with this drug as single agents, namely a phase 2 clinical trial comparing 2 different doses of lucitanib, 10 and 15 milligrams, and this is done in all breast cancer, so ER positive, HER2 positive, and triple negative as single agent. And patients that may benefit from FGFR inhibitors are patients that have an FGFR1 amplification of their tumors, but also patients that have an alteration on the 11q amplicon, such as FGF3, FGF4, and FGF19 or CCND1 alterations. These patients, because of having this pathway in overdrive, secondary to these mutations, really could derive specific benefit from these medications, either by itself or in combination with endocrine therapy, anti-HER2 therapy, or chemotherapy. The challenge of targeted therapies nowadays is finding out in whom these therapies would work best. We are not quite yet refined enough from a biomarker point of view to understand which are the patients that are going to benefit the most from the combination of targeted agents with conventional therapy. Since we treat patients not only to make them live longer, but also to give them a good quality of life, really knowing who precisely needs the additional drug is key, since a lot of these targeted therapies have common side effects that overlap with some of the chemotherapy side effects. Namely, CDK4/6 inhibitors, for instance, have myelosuppression as a side effect, which is a common side effect seen with chemo. And that usually, even though is not something that patients feel, it's something that makes them come more often for blood work, sometimes have to take antibiotics, sometimes have to interrupt medications, cause stress, whatnot. So side effects like this one, or the fatigue or GI toxicities that may be seen with some of these agents, make them not as enthusiastic as we would be considering that they are not chemotherapy. Therefore, the knowing in whom we should use these agents in combination with conventional treatments or by themselves is still a big part of the homework we need to do in clinical trials nowadays. Specifically with CDK4/6 inhibitors, to use that as an example, we have an agent that has some toxicity, not as much from a quality of life point of view that patients feel, such as myelosuppression, but patients have to come in more often to get blood draws because of the potential myelosuppression. If they are myelosuppressed and they have a fever, they will need antibiotics. So that, added to some of the GI toxicities we can see with this drug, it's obviously something that, even though it may prolong survival, it obviously will impact from a quality of life point of view. So the challenge of adding these drugs to conventional treatments that are quite well tolerated, such as endocrine therapies, is to manage the side effects while seeing the benefit. And therefore, that's why this may not be necessarily for all patients. Additionally, the other challenge that we may see is that some of these targeted agents are bound to result in resistance to them as well. And circumventing that may mean adding yet a third drug to the combination, and that certainly comes with a price, meaning higher toxicity.